Before I introduce our illustrious speaker, we have a couple housekeeping items to attend to. First and foremost, as program chair of the Statistics and Data Science Interest Group, I want to thank our ongoing sponsors for this interest group. That includes the University of Maryland Claude D. Pepper Center, Older Americans Independence Center, and the University of American School of Medicine Center for Research on Aging, and Doctors Teresa Kim and Nathan Parrish. Now, if you want to be a sponsor and you want to be acknowledged on a future webinar, we have a QR code that you can access. As soon as I'm done talking, I will also provide a link in the chat. If you're joining this webinar and you are not currently on our email list, I will also drop a link in the chat for how you can join, so you'll never miss an update on our activities. And I also want to give you a sneak preview of our next activity, which will be next month at the Gerontological Society of America annual meeting in person in Seattle. So this will be on November 16th. We are teaming up with GSA's Measurement Statistics and Research Design Interest Group to host a grant writing webinar panel aimed at folks who are either methodologists or folks who want to learn some best practices on how to incorporate modern statistical and data science methodology into their grant applications. I will also drop more detailed information about that in our chat. So I see we have quite a few people joining. So I'm going to take the opportunity to introduce our speaker. We are delighted to have Yates Coley, who's joining us from the West Coast. They're an associate biostatistics investigator at Kaiser Permanente Washington Health Research Institute and an affiliate associate professor in the Department of Biostatistics at the University of Washington. Dr. Coley's statistical research program focuses on developing statistical methods that enable rapid evidence generation and this synthesis from electronic health records data to inform and improve healthcare delivery. They collaborate in many content areas, including mental health, aging, cancer, health services, and health equity. Dr. Coley has also been recognized with the Emerging Leader Award from the Committee of Presidents of Statistical Societies and with the Healthcare Heroes Award from the Puget. I never know if that's Puget or Puget. Is it Puget? Puget Sound.
Puget, yeah.
All right, we'll go with that. With Puget Sound Business Journal. And the title of their talk is The Electronic Health Record Risk of Alzheimer's and Dementia Assessment Rule, or eRADAR, External Validation and Embedded Pragmatic Clinical Trial in 2 Real-World Healthcare Systems. So I'm going to stop sharing so Dr. Coley can share their slides, and we are going to get going. Dr. Coley, take it away.
Great. I believe you can all see my slides now and hear me as well. Let me know if that is not the case at any point. So hi, everyone. Thanks so much for joining for this webinar. Thanks to Michelle, Charles, and Donna for organizing, and I'm really excited about this new interest group. So today I'm going to talk about 2 projects, one validating the eRADAR model and the second assessing its use in a randomized pragmatic trial. So since the talk is in kind of 2 sections, I'm going to stop after the first section where we talk about validation of this prediction tool, and there'll be an opportunity to ask questions about that then before I go on to talk about the pragmatic trial. So put your questions in the chat as they come to you, and we'll be able to answer them there when we take a break. Of course, at the end of the talk, happy to answer questions about any aspects of the work.
Please put questions in the Q&A.
Oh, sorry, not chat. Put questions in the Q&A. Thank you, Michelle. So the research I'm going to discuss today is a National Institutes of Aging funded collaboration between teams at the University of California at San Francisco and Kaiser Permanente, Washington. And many folks have contributed to what I'm going to be talking about. The full study team includes a much larger group of contributors, including qualitative researchers, survey staff, and research interventionists. So just a quick outline for my talk today. After giving a high-level introduction to the background and objectives of the study, I'll present our AIM-1 analysis to externally validate the eRADAR algorithm's performance for identifying undiagnosed dementia. I'll walk through how we approach validation of this clinical prediction tool using electronic health records data and what we found, both in terms of overall performance and performance within subgroups. Then I'll present the trial design and protocol for our AIM-2 multi-site pragmatic trial to evaluate the impact of implementing the eRADAR model to guide cognitive screening. So here I'm going to discuss statistical challenges in the design and conduct of cluster randomized pragmatic trials. So for some background, in the United States, approximately 6.2 million older adults are currently living with dementia. Prior studies estimate that only about half of those adults have received a diagnosis. So people who are lacking a dementia diagnosis might not be getting the support they need, leaving them vulnerable to potential harms, including fragmented medical care, preventable illnesses, safety problems such as car and firearm accidents, and financial abuse. To date, the United States Preventative Services Task Force has concluded that there is insufficient evidence on the benefits and harms to recommend universal dementia screening for older adults. So there's a critical need for new strategies for early detection that are acceptable to patients and clinicians and that maximize benefits while minimizing harms. A targeted screening approach focused on those at elevated risk of dementia might be more effective and feasible for addressing the problem of undiagnosed dementia. So the acronym eRADAR stands for the Electronic Health Record Risk of Alzheimer's and Dementia Assessment Rule. And eRADAR is a previously developed prediction model that uses routinely collected clinical data from the electronic health record, or EHR, to identify patients with increased risk of having undiagnosed dementia who could potentially be targeted for assessment. Predictors in eRADAR include dementia risk factors like gender and age, diagnoses like stroke, medications including antidepressants, vital signs like weight loss, and healthcare utilization such as emergency department visits. So eRADAR was originally developed and validated in a research cohort that's embedded within Kaiser Permanente, Washington. Participants who are enrolled in the Adult Changes in Thought study have study visits every other year that include thorough cognitive assessments. And those cognitive assessments reflect a gold standard measurement for whether someone has dementia at the time. So the outcome of undiagnosed dementia was determined by comparing this gold standard dementia assessment from a research study visit to diagnoses that were in the EHR prior to that study visit. Study participants found to have dementia during their research assessment who didn't have a diagnosis in the electronic health record were said to have undiagnosed dementia. Within the ACT study cohort of patients without any dementia diagnosis in the EHR, a prediction model was developed using risk factors available in the EHR, not using any of the research study data that was collected to estimate the eRADAR model. So in this original sample, the test set area under the curve was 0.82 with a 95% confidence interval from 0.79 to 0.74. So it showed pretty strong risk discrimination. So in A1, the eRADAR model was validated in 2 health systems. The goal of this aim was to evaluate generalizability of eRADAR from a research population to a real-world clinical population at Kaiser Permanente, Washington, and also to assess the transportability of the model to a non-integrated healthcare system, UCSF. Like most U.S. healthcare systems, the University of California at San Francisco receives little information about healthcare occurring outside of that system on their patients that they see there. Other goals of the project include examining performance of eRADAR over time, including across the 2015 transition from ICD-9 coding to ICD-10, and assessing performance across racial and ethnic groups to ensure that implementation of the model would not exacerbate existing inequities in dementia diagnosis and treatment. Following validation in AIM-1, the second aim of the study was to conduct a pragmatic randomized trial to evaluate the effect of using the eRADAR model to guide additional cognitive screening. So we'll examine the effect of dementia diagnosis rates, utilization, and patient and family member experiences. I'll note that there's also a qualitative component to the clinical trial that I'm not going to be discussing today, but it's incredibly valuable for putting the quantitative results in a context. So this study takes place in two health systems. First, there's Kaiser Permanente Washington, which is a not-for-profit integrated health system providing insurance coverage and medical care in Washington state to about 700,000 members. And this includes about 98,000 Medicare Advantage beneficiaries. And then the University of California at San Francisco, or UCSF, is a not-for-profit academic medical system that provides primary and specialty care. There are 3 primary care practices within the UCSF system that participated in this first in-one validation study, and they take care of about 48,000 patients, including 12,000 Medicare or Medicare Advantage beneficiaries. That should say Medicaid there. So first I'll be talking about AIM-1, this external validation study, and this work was published in the Journal of General Internal Medicine in 2023. So our retrospective validation study of the eRADAR algorithm was designed to reflect how we think the model would be implemented in typical healthcare settings. So we envision that eRADAR scores would be calculated periodically for patients who don't currently have a dementia diagnosis, and then those patients who are identified as high risk would be recommended for cognitive assessment. Patients who remain engaged in care at the health system and don't have a dementia diagnosis would then have their eRADAR score calculated many times as they age. So for this validation analysis, we calculated eRADAR scores annually on January 1st of each study year in older patients who didn't currently have dementia, based on clinical data in the prior 2 years. Their risk factors were assessed over the prior 2 years to calculate their eRADAR score. And then we followed patients prospectively to identify incident dementia diagnosis in the subsequent 12 months after that index date. People could be included in the sample for multiple years if they were enrolled in the health plan and met eligibility criteria and didn't have a dementia diagnosis in prior years. People could be included in the sample for multiple years, and so then predictive performance was evaluated at the person year level rather than the person level to correspond to this design. So the inclusion and exclusion criteria were evaluated on January 1st of each study year. It was 2010 to 2020 at KP Washington and 2014 to 2019 at UCSF. The validation analyses included all patient years for people who were 65 years or older, who met site-specific criteria for adequate utilization within the healthcare system to ensure availability of their clinical data. And exclusion criteria included having a dementia diagnosis or dementia medication or other documented memory problem in the prior 2 years, and being on hospice care. Following that sample definition, we had 688,599 person years at KP Washington and 47,348 person years at UCSF. Both sites had a similar age and gender distribution. We did see that UCSF had considerably more patients whose self-reported race recorded in the medical record was Black, Asian, or Hispanic, and that tracks with the populations that each of these health systems serve in the surrounding geographic area. The distribution of eRADAR scores at each site was also similar. The median predicted risk of undiagnosed dementia at both KP Washington and at UCSF was 1.0%. So eRADAR was developed to predict risk of undiagnosed dementia, which was identified for the ACT research study participants via formal assessment at research study visits. But in real-world clinical practice, cognitive screening assessments are not routinely done, so there's no comparable measure of undiagnosed dementia available in the EHR. So as an alternative for these validation analyses, we define the outcome as incident dementia diagnosis within 12 months of January 1st of the index year as a proxy for undiagnosed dementia. Given that dementia diagnoses usually occur relatively late in the disease process, we hypothesized undiagnosed dementia was likely present at the start of the year in which it was diagnosed. So at Kaiser Permanente Washington, we observed 7,631 incident dementia diagnoses, which is a rate of 11.1 per 1,000 person years. At UCSF, the event rate was less than half of that, with 216 new dementia diagnoses and 4.6 events per 1,000 person years. We may be able to hypothesize several possible reasons that incident dementia diagnosis rates were lower at UCSF, but this study wasn't designed to examine that question. So as a note, the outcome observation was censored for disenrollment from the health plan for Kaiser Washington and for death at both sites. So our performance measures were adjusted for censoring using inverse probability weighting, which was particularly important because we expect older adults to have higher eRADAR scores and also have higher mortality rates. So here were the findings from our validation study. The area under the curve, or AUC, of eRADAR at KP Washington was 0.84, with a 95% confidence interval ranging from 0.84 to 0.85, which means that the probability that a randomly selected person year with an incident dementia diagnosis had a higher eRADAR score than a randomly selected person year without an incident dementia diagnosis was 84%. So while the AUC was lower at UCSF at 79%, this is still a strong AUC. And this AUC indicates that eRADAR accurately discriminates between high and low risk dementia risk in this health system. The confidence interval for UCSF was wider because there's a smaller population observed over fewer years. So we observed a smaller absolute number of events and thus have less precision for all of our performance estimates. We also examined classification accuracy using various percentiles of the eRADAR score distribution in each sample as a threshold for classifying patients as higher risk for undiagnosed dementia or not high risk for undiagnosed dementia, since that's how we expect health systems would use eRADAR to target patients for cognitive assessment. So in this table here, I show the sensitivity and the positive predictive value, or PPV, using the 85th percentile of the eRADAR score. That is classifying person years with an eRADAR score in the top 15% as high risk. So we use this threshold. We have a sensitivity of 66% at KP Washington and 56% at UCSF. And that means that this threshold would accurately classify 66 and 56% of person years respectively with an incident dementia diagnosis as high risk. We would capture 66 or 56% of those true cases using this prediction rule at that threshold. The PPV at this threshold is 3.8% at KP Washington and 1.6% at UCSF. We expect a higher PPV at KP Washington than UCSF for a model with similar performance because the event rate was higher at KP Washington. So PPV is the probability that a person with an eRADAR score above the 85th percentile had an incident dementia diagnosis in the following 12 months. And we expect this to be low even for a very accurate risk prediction model, since dementia diagnosis is relatively uncommon. PPV is driven by the event rate in addition to the performance of the model. So in the context of rare events, it can be helpful to consider how much more information the risk score gives you compared to the baseline average. How much more do you know about somebody's risk if you have their eRADAR score versus if you just know the average event rate in that population? So for both KP Washington and UCSF, we see that the observed event rate in this top 15% risk strata, as measured by the PPV, is 3.5 times higher than the average dementia diagnosis and incident rate in each of those samples. Still, this relatively low PPV highlights the importance of pairing the eRADAR model with a low-cost, less intrusive intervention, because most people flagged as high risk will not have dementia. So the purpose of this model is to identify who's at high risk for undiagnosed dementia, to prompt additional screening, not to be a tool to say, well, we know this person has dementia because they have a high eRADAR score. It is not a diagnostic tool. It's a screening tool that can be used for additional assessment. So we also evaluated eRADAR in different subgroups. So first, we examined how well the eRADAR score performed over time. So this is particularly important for clinical risk tools that a health system plans to use prospectively. You don't want to see large swings in performance over time in your retrospective validation. That would make you very worried about using it in the future because you wouldn't have confidence that the performance you've seen in the past would stay the same. If you implement the model, you want to have some of that certainty that it'll continue to perform as expected into the future. So the temporal analysis I'm showing here is the area under the curve at KP Washington across the transition from International Classification of Disease Codes, or ICD version 9 to version 10. So the ICD 9 to 10 transition happened in October of 2015. And this might have impacted identification of both dementia predictors and outcomes in the EHR data. When we're running this study, we had to have a separate set of diagnosis codes for pulling all the risk predictors and for pulling all of the outcomes from our virtual data warehouse with our EHR data. So we had to identify the appropriate diagnosis codes in the ICD-9 era and the ICD-10 era. So we wanted to validate how the model performed across this transition. So we looked at the years preceding the transition up to 2014, when all of the diagnosis codes for all the risk predictors and the outcomes would have been only used ICD-9 diagnosis codes. And then we have what we've labeled here as our bridge years, where the predictors and or outcomes would have used both ICD-9 and ICD-10 data. And that carries us into 2017, since the eRADAR predictors have a look back period of 2 years. And then from 2018 on, we have the ICD-10 years, where we know that our predictors and our outcomes only use the ICD-10 diagnosis. So we saw that performance of eRADAR was consistent over time here within KP Washington, so it wasn't affected by this transition or other changes in care patterns at either of these health systems. We have a similar graph for UCSF that shows stable performance over time with a wider confidence interval because they have a smaller population and a smaller number of events. We compared similar analyses that looked at each calendar year and saw stable performance over time in both the area under the curve and in estimates of like sensitivity and PPV at different thresholds that we were interested in. So we had confidence that this model would have stable performance over time. We also conducted subgroup analyses looking at performance in racial and ethnic groups at each site. Because of the documented racial disparities in dementia diagnosis, as well as more general concerns about how structural racism is manifest in degrading the availability and accuracy of electronic health record data for minoritized populations, we wanted to ensure that the eRADAR score performs similarly well across subgroups. And one thing we had in mind when we were looking at this graph is the pragmatic trial that we're planning. And we wanted to ensure that patient populations benefited similarly from the planned interventions and the more general benefits of participating in research. So here I'm showing the sensitivity of the eRADAR score at the 85th percentile of the risk score at each site, which is the threshold that we decided to use for the pragmatic trial. The pragmatic trial, everyone who had a risk score above this threshold would be labeled as high risk and enrolled in the trial. I'll give more details of the trial later, but this is what we had in mind when we're looking at this graph. So at KP Washington, the sensitivity of the eRADAR score at that threshold appears similar across racial and ethnic groups. We see that the sensitivity is about 60%, meaning that 60% of the eventual dementia diagnoses in the following 12 months would have been flagged by the eRADAR score using this threshold. We do see wide confidence intervals for some of the less prevalent racial and ethnic groups within the KP Washington patient population, but the point estimates and the confidence intervals are hovering around the same area. At UCSF, we identified potentially lower sensitivity or true positive rate of the model at this threshold for Black and African American patients. But the confidence intervals weren't wide enough that this was for this to be a statistically significant result, but we considered these findings when planning a pragmatic trial of the eRADAR score. So we spent a lot of time debating how this finding of potential disparity should affect our study design. We see that the sensitivity at UCSF for Asian, Hispanic, and white non-Hispanic populations is about 60%. It ranges here between 50 and 70% with confidence intervals, but that the sensitivity among Black patients at UCSF was about 30%. So we were concerned about this this disparity in the impact of using the model. So on one hand, using a single threshold for all racial and ethnic groups would result in flagging fewer Black patients at UCSF as high risk. This lower sensitivity for Black patients, we dug into the data and it found that when we had a threshold that flagged 15% of patients, it was not flagging 15% of Black patients. And that's why the sensitivity of the model was not as good. So if we use this one single threshold for identifying all of the patients, we'd be flagging fewer Black patients at UCSF with high risk, enrolling fewer Black patients in the study, and then offering the intervention to fewer Black patients. On the other hand, the benefit of the intervention that we're testing hasn't been established yet. There's not equipoise. That's why we're doing the study. So we don't have this concern that we're inequitably distributing an evidence-based practice, but we do have a concern that we're not equitably distributing the possible benefits of participating in the research study. So ultimately, we decided to use a separate threshold to identify high-risk Black patients at UCSF because we determined that the harms of inclusion in the study didn't outweigh the benefits to the individual patient. And in the overall sample, increasing enrollment of Black patients is going to increase the statistical power for us to evaluate the intervention's effects in racial and ethnic subgroups and understand what underdiagnoses might be taking place there so that we could either improve the eRADAR score or improve the implementation of the eRADAR score so that we didn't see these same disparities if we were to use the model in the future. So one limitation of the validation analysis presented here is that dementia is currently underdiagnosed in the EHR. So we're validating against a misclassified outcome. In particular, we know that the positive predictive value of the eRADAR score for true dementia status at any of these thresholds is going to be greater than what was estimated here because dementia is so underdiagnosed. So this is the major motivation for doing this project and doing the pragmatic trial that follows. So the performance estimates for this validation study should be considered in light of this limitation and the outcome ascertainment and interpreted accordingly. So for example, the estimated AUC refers to risk discrimination of the eRADAR score with respect to incident dementia diagnosis recorded in the EHR. It can't be interpreted as the AUC for undiagnosed dementia. Overall, despite this limitation, we were able to use EHR data to gain some understanding of the predictive accuracy of the eRADAR model in a real-world care setting in order to confirm its potential usefulness and inform the pragmatic trial that follows. So findings for our upcoming trial will then improve estimation of eRADAR's performance among high-risk patients by providing formal dementia assessments and allow us to kind of reinterpret these results and kind of re-understand the validity of the eRADAR score given what we observe to be the underdiagnosis rates. That's a pause point that I have here before I get on to talk about the pragmatic trial. So what questions do folks have?
Hey, Yates, we have 5 questions in the chat. The first 2 can be combined. So Teresa Kim is asking, at Kaiser Permanente and at UCSF, are there both Medicare fee-for-service and Medicare Advantage?
At KP Washington, they only have Medicare Advantage patients. At UCSF, there's Medicare Advantage and Medicare fee-for-service. I can't remember the exact distribution, but it's in the paper and I can look it up later if we have time.
And then there's another question where the attendee wants to know what is the specificity of the eRADAR score. They're interested to know how many false positives there were.
Sure. So when you have a rare event, the specificity is pretty close to the proportion of visits that you're flagging. So if we flag 15% of visits, we expect the false positive rate to be about 14%. It's not going to be as high as the percent of visits we flagged because some of those are true positives. So we would expect the specificity at the 15th percentile to be something like 86 at 87%. It doesn't really tell us as much about the performance of the model. It tells us more about how many patients we flagged and how rare the event is. So that's why we focused on the sensitivity and the PPV and the reporting here.
All right, great, thank you.
And
Daniel Schulman.
comparably, the negative predictive values are all like 99 point something percent. So I'm sure they're in the supplement for this paper, but we don't tend to look at them. It's all driven by the rare event nature.
Thank you. Daniel Schulman is asking, do you have information on other socioeconomic variables that might differ between KP Washington and UCSF? And have you looked at how they might be influencing the differences in sensitivity across the racial ethnic groups?
So at Kaiser Permanente Washington, within our virtual data warehouse that we use for research purposes, we do have some census level variables that we've through just like geocoding a folks' address and linking to census block. UCSF does not have that available to like all of their research on kind of an enterprise level. So we did not do that analysis in this study because we didn't have that comparable data. That just was like out of the scope of what we were funded to do at UCSF. In terms of including those predictors in the model, we want to use information that's available only in the EHR. So that information right now, it only lives in our research virtual data warehouse setting. And so we wouldn't want to have a prediction model we wanted to use clinically that relied on it. Both, I know KP Washington is doing a lot with social needs screening, and that's something that eventually could be incorporated into prediction tools, but it's not widespread enough to use for either for like clinical prediction models you want to use on a widespread basis or for any research understanding of the population.
Okay, great, thank you. Sylvia Miramontes has some questions about the applicability of the eRADAR model or, analogous kinds of models across different clinical settings. And as an example, they mentioned that UCSF is a tertiary center, whereas Kaiser's more of a healthcare system. And in particular, UCSF, dementia diagnoses can vary significantly. Some get it at the primary care, akin to Kaiser, while others go to specialty clinics. And so then the question is, how do you envision applying eRADAR environments where a patient's clinical trajectory might differ markedly from that of Kaiser? And furthermore, how can we ensure that diagnoses made using this model adhere to a gold standard, effectively minimizing the risk of misdiagnoses before making predictions and in the follow-up process?
Thanks. I might ask you to remind me of the second part of that question. So for
Sure.
the first part of the question about the differences between KP Washington and UCSF settings, you're absolutely right. And that's one of the major motivations for validating this model within UCSF. So the UCSF clinics that participated in the study are primary care clinics. So these are patients that are paneled to a primary care provider within UCSF and have seen that provider. I believe it's at least twice within the past 36 months. I could be getting the exact criteria for engagement wrong there. So they have to be an active patient engaged in care. So we have confidence that they're receiving at least some of their primary care at UCSF. And so they would be part of the population that this model would be then used on in the future if UCSF primary care decided to adopt this model. We are able to link to all the specialty care at UCSF to see what the dementia diagnosis rates are. But if somebody receives care outside of the UCSF health system, then we don't have that included in our records data. So that means we know that we're undercounting the risk factors. And means we know we're undercounting like who has a dementia diagnosis. That kind of the effect of that underdiagnosis can only move in one direction. But despite that limitation, we still saw that the model performed pretty well, which makes us confident about using the model in the future. So this is where prediction tools may not be the data that you have for prediction is likely not the data you'd want to use for an inferential study if you were, say, trying to like do some causal inference on the effect of these risk factors on the outcome. You'd want to have the most accurate predictor data you could have. You would like work through that kind of incompleteness and missing data problem. You'd figure that out, so you can make accurate inference. In a prediction model setting, when we want to use this model in the future in clinical practice, we just we want to see how well the model works with the data we know we have in the future. And so that's what we've done here. And we see that it still works pretty well. What was the second part of that question?
So the second part was building onto that first part, kind of given these heterogeneities, how do you envision applying eRADAR environments where a patient's clinical trajectory might differ markedly from that at Kaiser? And how can we ensure that diagnoses made using this model adhere to a gold standard, effectively minimizing the risk of misdiagnoses, both before making predictions and in the follow-up process? And before you answer, I'll say that we're going to take questions until about 2:40, and then we're going to let Yates finish up the rest of their talk, and then we'll circle back to the remaining questions.
Yeah, so I think I already answered some of that, like what we think about in terms of transportability. And I'd say the second piece is that this model is not a diagnostic tool. Just because somebody has a high eRADAR score, you wouldn't want to put like a dementia diagnosis in their chart and start treating based on that. If someone has a high eRADAR score, that would be a prompt for their provider to do additional cognitive assessment to see if they do have dementia present, and then make treatment decisions accordingly.
Okay, next question is, can you explain why the 85 percentile threshold was used to identify high-risk patients?
Yeah. So with any prediction model, when you're thinking about using it in clinical practice, you want to look at the accuracy, kind of the sensitivity and specificity and PPV at any of those thresholds. And you also have to think about your capacity for like, how many people could you actually give this intervention to? So we actually did power calculations for, I think it was like the 10th, 15th, and 20th percentile of the risk score, seeing what would be the power up for our randomized trial that I'll talk about next if we use these different thresholds. So of course, increasing the sample size, from 10% to 20% of patients is going to increase your power a bit, but you don't get as much bang for your buck for that like 11th to 20th percentile group of folks, because their PPV is going to be lower than the folks who are in that highest 10th percentile. So we did power calculations at using the PPV at these various thresholds to understand what our outcome rate would be, and then to look at what the minimal, whether we were powered to detect relevant clinical effects of the eRADAR intervention.
Okay.
I think that sets us up nicely to talk about AIM-2.
Okay, great. And
Thank you
for
all
those
for
of
the
you who still
questions.
have questions remaining, we are going to circle back after Yates finishes their talk.
So I'm going to move on to discuss the pragmatic randomized trials we conducted or in the process of conducting to evaluate the impact of using the eRADAR score to identify folks who are at higher risk of undiagnosed dementia, invite them for cognitive assessment with the hopes of improving dementia diagnosis and overall patient outcomes. So to overview the design for the study, we're conducting it in 2 health systems, KP Washington and UCSF. The population eligible for enrollment are those that are 65 years and older who have a high eRADAR score, defined as an eRADAR score in the top 15th percentile. That's a different threshold at KP Washington. It's 2.6%. At UCSF, that's a 2.8% for non-Black patients. And then we use that separate threshold for Black patients to flag 20% of Black patients at UCSF, and their threshold was 1.9%. And then we applied similar eligibility criteria as we did in AIM-1. Randomization was done at the provider level because the intervention did involve some interaction with providers, which could lead to contamination if we had done randomization at the patient level. So patients who were assigned to the intervention arm received an invitation to complete a brain health visit with a research interventionist. And that brain health visit included cognitive assessments. So importantly, the research staff didn't assign a person a diagnosis for dementia or alternatively MCI, but they did make a determination of likely dementia or likely mild cognitive impairment, shared this information with the study participants provider, and then facilitated follow-up between the study participant and their primary care provider. The control arm had no intervention and no interaction with the study. And the primary outcome for the study is presence of a dementia diagnosis in a patient's clinical records data within 12 months. So I'd like to highlight the pragmatic elements of this study. With KP Washington at UCSF, we were using, real world clinical populations and settings, KP Washington representing an integrated care setting, UCSF representing a more common setting where you see the patients when they're in your healthcare system, but you don't see all of their care, as was highlighted by one of the questions we had. The population of eligible patients was identified via the electronic health record, and every patient who is eligible is included in the analytic sample. We received a waiver of consent from the IRB for collecting this initial baseline data on everyone who is eligible, and have a waiver of consent for collecting the outcome information as well. Randomization was done at the provider level. Providers could choose before the study, before they were randomized, to opt out, but very few did. So our intervention, this is the one place where the study is less pragmatic and doesn't quite reflect how it'd be used in practice. Here we had research staff doing outreach, assessment, tracking, and follow-up. And this was paid for by the research study. In the future, if eRADAR is shown to be effective, then either the health system would need to have a person who does that outreach and assessment, or it would be the responsibility of the provider to do whatever follow-up they had the bandwidth to do, or integrate the eRADAR score into their normal clinical practice. And the primary outcome of dementia diagnosis within 1 year is ascertained in the electronic health record. So it's available for all patients and ascertained in the same way for all patients in the study. So I'm going to talk through some of the design and implementation challenges we had, and kind of how I thought about them as a statistician and how we tackle them as a team, given the pragmatic nature of the study. So because of the resources required to do patient outreach and conduct these brain health visits, and since this is all done by centralized research staff, you can't just turn the intervention on at the start of the study. You need to do some rolling initiation. And in that regard, it doesn't reflect how the model would be used in practice, where it's kind of live at all times for any provider to know if their patient was high risk. So because we had to roll the study out over time, we went to different clinics at different times, and within clinics, we did different patches of providers at different times. We did not randomize the order of clinical deployment. That was based on clinic chiefs that were interested in having us at their clinics at that time, as it's going to happen when you're doing kind of a pragmatic study, and you've got to impose your research study and try to integrate it into clinical care. But the order of provider initiation was randomized. So all eligible patients can't be identified at the start of the study. The patient risk and eligibility is time varying, particularly among an older population with a high comorbidity burden. We needed to identify patients and their eligibility for the study when their provider was randomized. So as a part of this phased rollout, which means we couldn't just identify everyone who is eligible. When we started the study, I had to do this about 24 times. And the consistency of code run on EHR data is not guaranteed. We need to have our risk scores that we're generating, they need to be accurate. And if something changes in terms of how certain data are collected, or like someone's weight is stored in the electronic health record, it can throw off the score. So we needed to do manual review of data summaries for each round of initiated providers to make sure that all of our code was running against the EHR as expected. So with provider level randomization, we have variability that's likely informative in cluster size. So we randomize providers within matched pairs, where the pairing was done based on the eligible panel size, the number of patients that providers saw that were 65 and older and met eligibility criteria. And then because we were doing this randomization many times over the course of the study, we were able to use a constrained randomization process to try to keep the intervention and control arms similarly sized. It was not perfect. There's still variability in the total size, but that kept one arm for just kind of running away with it if they happen to be on the larger end of those pairs when we did the randomization. So providers are going to enter, exit, or have interruptions in practice. So this idea that we're just going to like march through a practice and randomize each of the providers when it's their turn is more difficult because providers are going on parental leave, they're going on sabbatical, they're retiring, new people are hired. And so we tried initially to like accommodate this by like, oh, well, we'll not randomize someone with the first block of providers, we'll randomize them later. And that ultimately we found did not really work. And we just had to randomize a providers panel, even if they weren't available at that time, knowing that that's typical clinical care and that other providers would see their patients based on the follow-up from their cognitive screening. So this whole process, doing it again, I think I said I did it about 24 times across the 2 different sites, could be really time consuming. And I'll just quickly summarize what like putting this all together for each round of provider initiation looked like. First, we had to, at each clinic, we'd have to confirm provider eligibility. If they were available, we'd give providers a week to send us an email to choose if they wanted to opt out. Luckily, very few did. Then we would pull their up-to-date panel size information and we'd randomize the providers where we'd first pair providers based on their current panel size, do the constrained randomization to try to get some balance between the intervention and control arm. And then we would have to randomize the order of initiation if there were too many providers to be initiated at once, given on the capacity within our like survey program and our research interventionists. And then once we've randomized the providers, we identify all of their eligible patients based on their eRADAR score. We do all that baseline data collection based on their randomization date. And then I go through and do all the data checks. I look at the consort diagram and see if we're applying eligibility criteria in a similar way. Are eRADAR scores distribution similar? Are we applying the threshold similarly, or did someone like multiply a proportion by 100 and now we're not flagging the right number of people, something like that, and make sure the distribution of baseline covariates is similar. And then the intervention providers had an opportunity, if they wanted to review their patient list, where they could exclude patients that they knew were already undergoing some sort of workup, just didn't have a diagnosis yet, or they could exclude patients that they knew, say, were like had end-stage cancer and were dealing with other things and would not appreciate an outreach from the research study. I'm going to take a couple minutes to talk now. I'm going to skip the safety monitoring that we did for the DSMB so that we can get through to some more questions. So the enrollment completed in the spring of this year, and the brain health visits, all of those were completed this summer, and we're currently in our 12-month follow-up period. So just some closing thoughts before we talk about some more questions. Meaningful validation of clinical prediction models and design of embedded pragmatic trials really require thinking about how interventions will be delivered in practice. And sometimes that means that the data quality for the validation isn't what we would have if we were doing an inferential study, say an observational, like retrospective data analysis. So it's really kind of shifting your framework for thinking about how you're doing the study to focus on like what's going to generate meaningful evidence for decisions that should be made in the future for clinical implementation. So clinical prediction models can and should be evaluated with rigorous randomized control trials. Having a model that performs well is necessary, but it's not sufficient for ensuring that your intervention is effective. So even if the eRADAR score is incredibly accurate, if the outreach that is prompted by the eRADAR score doesn't actually like have the clinical impacts that we want, it kind of doesn't matter if the eRADAR score is good. We need to know if the intervention we're pairing it with is going to be effective. And similarly, if we're thinking about algorithmic fairness, like is this model going to be exacerbating racial disparities? Even if the model performs similarly well across subgroups that you're interested in, you have to have an intervention that's accessible and effective for all the populations. So to do that, we might need to modify and target interventions to your disadvantaged subgroups who might experience health disparities. So in this trial, preliminary evaluation of participation in the brain health visits shows lower rates of brain health visits for patients of color. So we're planning qualitative studies to identify barriers and facilitators to cognitive evaluation so that any future implementations of this intervention doesn't widen existing disparities in dementia diagnosis rates. And I'd say conducted embedded pragmatic trials is hard and complicated, as I just talked about for about 15 minutes. But it's worth it because you're able to get generalizable results, real world evaluation of effectiveness, and it also deepens collaborative relationships between researchers and their health system partners. So that concludes my prepared slides. Here are the citations for the validation study and our protocol paper. Thanks so much to the organizers for inviting me, and I'll try to get through as many questions as I can. If I don't get to yours, please email me at my KP email address here on the slide.
Thank you so much, Yates. It's nice to see a discussion on not just the analytical challenges, but the implementation challenges, because most of us only think of one or the other. And also thank you for leaving time for some of the remaining questions. And so most of these are referring to your AIM-1 findings. There was an attendee that wanted to know if there were different types of providers contained in the data, such as primary care, acute care, home, and community-based.
These are all primary care providers or family practice, internal medicine, but they're all practicing within a primary care practice.
Got it. Deborah Walton wants to know, given that there are disparities with respect to which patients receive dementia chart diagnoses, was there any concern during the study that implementation of such a measure would further exacerbate disparities for these patient populations and potentially stress dementia care structures within KP and UCSF?
Yeah, I mean, that's a major concern. So that was first why we looked at differences in the sensitivity of the model for observed dementia diagnosis rates, realizing that may not reflect disparities in like true underlying dementia rates. And when we run the trial, we want to understand amongst those folks who get the brain health visit, then we do have a more thorough assessment of their status. We can see if those, if the rates of dementia being identified in the brain health visits are higher for populations where we think that underdiagnosis may be systematically occurring. So that is one of the goals of the study, is to better understand what those true underlying rates are, so we could then update the eRADAR model so that it wouldn't exacerbate those disparities, and also to understand if our intervention is equally effective for different groups of folks. So the intervention paired with the model wouldn't be exacerbating those disparities.
Thank you. Batul Yawar wants to know whether there were differences in the EHR measures between UCSF and KP, or even within UCSF between races to cause the sensitivity differences seen in the graphs.
Sure. So one of the differences, if I'm recalling correctly, there was a bit of a difference in the age structure. I believe on average, the Black patients tended to be a little younger. So that's going to lead to lower eRADAR scores, and that's going to lead to having fewer people flagged at a certain threshold and lower sensitivity. That being said, again, we want to consider the possibility that we'd like every population to benefit equally from using the model. And there are many different ways and approaches to conceptualizing that. I don't remember if there were other major differences in our study. And I tried to open up my table 1 here on the other screen, and PDF Adobe crashed on me. I don't remember anything that was like, oh, this is really driving the differences based on blood pressure or diabetes rates or anything like that.
So there wasn't really anything prominent that stood out. And
we have in the paper, we have all of the rates. We have all of the eRADAR characteristics described within racial and ethnic groups at both KP Washington and UCSF. if folks want to look up the paper or reach out to me for the paper and the supplement.
Great. So another attendee wants to know if, in addition to measures of model discrimination, if you looked at model calibration, particularly for the validation data set at UCSF.
Yeah, so we didn't look at calibration because wasn't as consequential for how we were thinking about using the model, since we're not thinking about like reporting somebody's particular risk score to them. We're thinking about like setting a threshold and like doing outreach to everyone who's flagged as high risk. That's why we focused on classification accuracy measures and didn't focus on calibration.
Got it. Frank Appia wants to know, do you think if you had identified the subgroups algorithmically in an unsupervised manner, that the outcome could have changed for better or worse?
So like unsupervised meaning that we don't know what we're not training on dementia status. In that case, I think you could be picking up subgroups that based on any number of different characteristics. So that could be similar in some way that's not necessarily like highly correlated with our outcome of interest here, which is dementia. So I don't think this is the right space for unsupervised learning. But if I'm thinking about this in a limited way, please let me know.
And this is a question, I'm not sure if this is for your AIM-1 or your AIM-2, but they want to know, how were high-risk patients classified in this model?
Yeah, so high risk classification was defined as having an eRADAR score that was above the 85th percentile or distribution of the eRADAR scores within each of those clinic populations. We defined that based on their most recent years of data so that we had a sense going into it that we'd be flagging about 15% of the patients. So then we would generate eRADAR scores for the providers who were randomized into the study, and all those who were eligible and had a risk score at or above those thresholds were considered high risk.
Okay, great. So this next question is regarding your AIM-2 work. And Daniel Schomlin wants to know, what resources, such as specialist time, does your intervention, specifically the brain health visit, require?
Yeah, so the brain health visit is going to take about an hour. We have research intervention specialists who conduct those visits and interact with patients during them, and then follow up with patients on any questions they have, and they facilitate follow up with the providers as well, and kind of some tracking to see if patients are like getting in for a visit. If someone's having memory concerns that they might need some more support, making sure that that connection happens. So it is time intensive.
Okay, this is the last question, and this also refers to your AIM-2. Deborah Walton wants to know, given the time and space constraints in primary care, were you also measuring for volume of referrals to geriatrics or neurology?
So we will be looking at referrals for imaging. We'll be looking at different lab tests that folks have done. Some of the utilization measures we're going to look at include, those referrals, lab tests, imaging, all of the workup that you would do for someone with suspected dementia. And it won't all be done by a primary care doctor. So if anyone enters a dementia diagnosis into a patient's chart in the following 12 months, that would count towards the primary outcome.
Okay, thank you so much, Dr. Coley. I'm looking at the time, and it's 3 o'clock Eastern. So I just want to thank you so much for this wonderful presentation. Please, if you're attending GSA next month, please come to our grant writing panel discussion. And we're always interested in having referrals for speakers for upcoming webinars. So if you know anyone who's a good speaker, or if there's a particular topic you want to see, please reach out. And everyone, enjoy the rest of your day. Thank you so much, all.
So much.